Hi folks, so this is a re-upload of my last lecture. I'm doing this again for you because of some audio issues in the previous one. So enjoy. Peptic ulcer and its pharmacotherapy. Let's discuss peptic ulcer first, a slight bit about the pathology of it. Peptic ulcer. A peptic ulcer is the erosion in an area of GIT, usually in the mucus layer of the stomach and duodenum. It occurs when the mucus layer is corroded by the gastric acid and the pepsin, which are secreted by the stomach cells. It's an erosion or destruction in an area of GIT, in the mucus layer of the stomach and duodenum. How it occurs is important. Here I mention gastric hydrochloric acid and pepsin. So it's pretty straightforward. Gastric acid, of course, can damage ulcers. The existing ulcers could be seriously harmed by the gastric acid. How pepsin could cause peptic ulcer, could increase the pain. Pepsin, as you know, is a proteolytic enzyme, and it causes the lysis of proteins. And you know the cell membranes are made up of proteins also. So anything proteolytic in nature would cause damage to the gastric mucosa. So not only the gastric hydrochloric acid, but the pepsin can also be a player, playing its role in the development of peptic ulcer, or the pain induced by that. Two types: gastric ulcer, duodenal ulcer. Yes, very common two types. Gastric ulcer, the name implies, stomach ulcer. Stomach ulcer, the ulcer that develops in the stomach. Duodenal ulcer or duodenal ulcer, you may pronounce it either ways. So duodenal ulcer, which occurs in the first part of the small intestine. And by the way, duodenal ulcers are more common than gastric ulcers. That was something new for you. I'm sure that could be new for most of the students. Before moving further, let me introduce you to one more thing that I normally discuss in pathology lectures. So why not discuss it here today? So, if you have a gastric ulcer, that gets worse by eating food. So if you have a gastric ulcer, you will feel pain with the food. As the food passes through the stomach, it irritates the ulcer. So if you have a gastric ulcer, the food comes and falls over those ulcer, and it causes irritation and pain of the stomach. Now, as the food passes along the stomach, enters the pylorus, is pushed into the duodenum, then the food takes up most of the gastric hydrochloric acid. So the food in the stomach would take up the hydrochloric acid, and thus a less amount of hydrochloric acid will be pushed here into the duodenum. And in such a case, if someone has a duodenal ulcer, that will be relieved with the presence of food in the stomach, while the presence of food in the stomach would irritate a gastric ulcer and would lead to pain. Now this stomach is quite used to the gastric hydrochloric acid. It's not that weak. It's a very robust organ. So if something falls over it, something foreign falls over it, like food, that would initiate the irritation, and the nerve endings would then feel, or they would signal the pain. You will feel the pain. I think this is enough for now. Let me move forward. causes of peptic ulcer. It's very important. Two main causes: H. pylori, long-term use of NSAIDs. Now, H. pylori is a gram-negative bacteria. These are gram-negative bacteria, and they live in the mucosa of the stomach, hiding from the gastric attack. So they are very mean. They know how to challenge the gastric environment and can flourish here, can live here without getting harmed. So as you can see, this is the lumen of the stomach. This one is mucosa. This layer is mucosa. This is muscularis mucosae, this one. And this is submucosa. And you can see that there are blood vessels in the submucosal layer. So H. pylori, the gram-negative bacteria with flagella, they live here. Now, everybody in the past thought that if a microorganism enters the stomach, it would be killed. And everybody thought like that until 1982, when it was discovered that H. pylori can thrive, can survive under such harsh acidic conditions, in such extreme pH conditions. The H. pylori is very smart basically, and it lives inside the mucosa, as I mentioned, to avoid acid attack. Now the stomach is a difficult organ basically for targeting systemic antibiotics. Thus H. pylori can colonize easily in the gastric mucosa. These bacteria grow best at neutral pH and fail to survive at pH below 4 or above 8.5. However, many microorganisms survive the gastric acidity during their transit through the stomach. So how they do this? How do they survive? They do this by releasing certain enzymes. For example, H. pylori can synthesize an enzyme called urease, which has a neutral pH, and thus it tries to elevate the gastric pH. In this way, the bacterium offers remarkable acid resistance. This is pathology. We can discuss it later on when we take up this lecture in pathology. Let's move forward. Next cause of peptic ulcer could be long-term use of NSAIDs. For example, someone is taking these drugs, these pain medication or anti-inflammatory medication for a chronic illness or chronic pain. They could face peptic ulcer because NSAIDs, if you remember, in one of my last lectures, one of my last class lectures basically, where I mentioned that these drugs inhibit the prostaglandins, the friendly prostaglandins, which have a protective role in the stomach. They basically guard this mucosa. They have a protective role, so they guard against the development of peptic ulcer. So for example, these drugs are taken, they can damage gastric mucosa, lead to peptic ulcer. These two are the main causes basically. H. pylori, long-term use of NSAIDs. Let's move forward. Risk factors of peptic ulcer: smoking, drinking alcohol, spicy food. Yeah, these are not the causes, but the risk factors. If someone of you was thinking that spicy food causes or is a cause of peptic ulcer, you were seriously mistaken, because not only spicy food, but drinking alcohol or smoking can worsen an existing peptic ulcer, but has not the capacity to induce a peptic ulcer themselves. So I mean, this is highly uncommon that these things would induce a peptic ulcer and would serve as a cause of the peptic ulcer. So they are basically the risk factors. There is one more thing that I forgot to write here is stress. Stress can be a risk factor for peptic ulcer. I mean, the mechanism behind that is still under investigation, but it can be a well-known risk factor for gastritis and peptic ulcer. So add one more to it. So that will be number 4, stress. And probably it's because stress stimulates the parietal cells to release more and more HCl into the stomach. So that could be one reason for that, of the peptic ulcer. Symptoms: feeling bloated, feeling gassy. That is one of the common features of peptic ulcer. This happens with any form of gastritis or heartburn, etc. So yes, these could be the initial symptoms. Burping or belching. Yeah, those gross burps sometimes. In Urdu we call it Dakar. In Arabic, atajasho. Correct me if I'm wrong. Some Arabic speaking guy, please turn up. Please turn up. Correct me if I'm wrong. Atajasho. Correct me even if I'm right. Please do that. Turn up. Come on. Anorexia, or lack of appetite. Yes, of course, if you're feeling bloated, burpy, there'll be anorexia, there'll be loss of appetite. Nausea and vomiting, quite understandable, yes. Hematemesis, melena, these two are serious. Hematemesis, emesis from vomiting, hemat from hematology, yeah. Hemoglobin, you know the name, you know these terms. Vomiting out blood, hematemesis. So how this happens? You can basically throw out blood if you have extensive injuries in the stomach. So a bloody vomit or vomitus could be a sign of, or a symptom of, peptic ulcer. Melena, that's dangerous also. Melena is basically passing out bloody stools. So hematemesis, now melena is in reverse direction, passing out blood in the stools, and it happens because there is oxidation of the iron in the hemoglobin that takes place while the stool passes through the ileum and colon. So the oxidation of iron in the heme leads to melena, black color stools. Now hematemesis, I just remember one more thing. Hematemesis, which is a classical symptom of the peptic ulcer, is also called coffee ground vomit. Coffee ground vomit. So that is quite unique about the peptic ulcer symptoms. Let's move forward. Next slide. Complications: bleeding ulcers, perforations, pyloric stenosis. Bleeding ulcers, yeah, you can easily get how a bleeding ulcer would develop from the discussion on the previous slide. Yes, this could be a complication. Perforation, or when there is damage or formation of holes in the stomach wall. I mean, the gastric acid is now digging holes, deep holes into the stomach, and the gastric acid thus can spill out or can leak out and fall on the other viscera, and this could lead to serious damage. So this is an emergency, and this needs surgery before the gastric acid could destroy other parts of the peritoneal cavity. It's important to manage it by surgery. Pyloric stenosis. Stenosis means narrowing. Now there's narrowing of the pylorus, and this happens because of the gastric acid injury. And there is widespread hypertrophy, increase in the cell size of the pylorus, which is an adaptive mechanism. Now the body is responding to the gastric acid attack and then that it leads to the narrowing of the pylorus, and that is quite a painful condition. Diagnosis: endoscopy, urea breath test, which is specific to H. pylori. So endoscopy. What is endoscopy? This is an endoscope, flexible endoscope, which is passed into the mouth, that lands into the stomach, and it can be pushed even further to the duodenum part. Now, this basically has a camera, fiber optic camera here, and also an illuminating torch. So the torch lights up this hollow organ, while the camera sends images or recordings to the operators outside. And this can not only be used for the diagnosis of peptic ulcer, but as I mentioned in the start, maybe if I forgot to mention, this could be used in the diagnosis of gastric carcinoma or stomach cancer. So if someone has peptic ulcer or a gastric cancer or gastric carcinoma, they might have the same symptoms, exactly the same symptoms, same presentation. So this endoscopy can be used for the diagnosis of both these conditions. Urea breath test, it's specific to H. pylori diagnosis. It's a radio-labeled carbon isotope thing. That will be discussed in pathology in detail, not in the scope of today's lecture. Treatment is important, yes, for macrotherapy of peptic ulcer. Misoprostol and H2 blockers or PPIs in NSAID-induced ulcers. So this is first a very important point in the pharmacotherapy of the peptic ulcer. Misoprostol is a prostaglandin analog, as you remember. In NSAID therapy, you may end up losing your friendly prostaglandin in the stomach, and it can lead to peptic ulcer. So misoprostol is a prostaglandin analog. It's something similar to prostaglandin, and that will inhibit the gastric hydrochloric acid. And when it is coupled with H2 blockers like cimetidine, famotidine, ranitidine, etc., or a PPI, for example, rabeprazole, pantoprazole, omeprazole, etc., so either of these two, along with misoprostol, could be highly effective in NSAID-induced ulcers. Now, you may go through the classification of these drugs, which have been discussed earlier on. Next is clarithromycin or amoxicillin or tetracycline or metronidazole or trinidazole. All these are antibiotics, and you know antibiotics are used against bacteria, not the viruses. And one proton pump inhibitor, so one or two antibiotics along with a proton pump inhibitor, sometimes together with bismuth subsalicylate, which has some antimicrobial actions also. In fact, it has a better effect in controlling ulcers caused by H. pylori when used with other drugs. Now, in complicated cases, and by complicated I mean treatment-resistant cases, which are not responding to these medications, one or two medications, you can combine 3 antibiotics instead of 2. You can combine 3 antibiotics, for example, amoxi, clarithro, and metronidazole. So metronidazole is flagyl, and they may be used together with a PPI or sometimes with bismuth subsalicylate. This H. pylori is quite nasty, and it requires treatment for up to 14 days, sometimes even more than that in complicated cases. So these are the two forms of therapy, one for the NSAID-induced ulcer, other one for the H. pylori-induced ulcers. And I think this is sufficient for now. I'll see you in the next lecture. Till then, bye-bye.